keep the presentation short, just go over the objectives and some prompts to frame the conversation so that we can spend more time hearing what you have to say. But as Michelle had said, you can submit any written comments to the rate setting eval at maine.gov email address, and we would be happy to read those. If you want to
Julia, I just wanted to jump in on one thing about the attendee list, because I know that a lot of people on this call are interested in knowing who is on the call. So when you click on that view all attendees, the list that comes up in the middle of the screen doesn't default to showing you the company that the person is from, but there is a button on there that looks like two buildings. And if you press that button, it will show you the company that they're from. That information is there for a lot of people. But also I wanted to point out that last night, everybody who registered for this session received an email from Jillian that has the full attendance list attached. So if you look around 5:45 last night, there's an email from someone named Jillian with a J, and her last name starts with K. And so that is sitting in your email box and has a full list of everybody who registered along with the organization that they're from. So I just wanted to let everybody know that.
Great, thank you. So if you can go ahead and move to the next slide. So just to kind of remind everyone, the purpose of the evaluation was to develop a system for establishing and maintaining rates that are sufficient for Maine providers, as well as ensuring Maine Care members have access to high quality services. And then to evaluate the rates and the rate setting system and to develop a plan for creation of a comprehensive, streamlined, and a coherent system moving forward. Where we're at in the process, so in November, we did release the cataloging and benchmarking report, and we had, prior to that, provider listening sessions in October, also some member listening sessions in November, and now we are at the December provider listening sessions. We plan to release a report with interim findings in January, and then the final report at the end of February, and that will include recommendations as well as a recommended process and structure and priority list. So the structure for the meeting today, our role is really to ensure participants keep their comment within the announced time limits. This is a slightly larger meeting than the ones we've had in the past. So I don't want to put a hard limit on time per se, but I would like everyone to think about 5 minutes. If it starts to creep up longer than that, and I think we have a lot of people with raised hands, I might ask you to wrap it up. But just really, if everyone could just be respectful of each other and keeping the comments to the topic under discussion so that we can make sure everyone has an opportunity to speak. We're going to ask you to, prior to commenting, to introduce yourself, your organization, and the services you provide. And if someone has said something you agree with, it's perfectly fine to just say you agree with them instead of restating all the points. And then again, just to respect time limits and each other's opportunity to speak. The purpose of today's meeting is to gather feedback related to additional points that you would like for consideration regarding the rate comparisons, and also then to give you an opportunity to talk about the sufficiency of your current rates and any issues related to the rates and their impact on access or sustainability. And to that end, we have some discussion prompts to help you frame the conversation with us. If you could move to the next slide. Thank you. So some prompts on how, to sort of frame your feedback to us. Are there assumptions or costs that are critical to consider that may be unique to Maine that wouldn't necessarily be reflected in another state's rates? Are there differences in payment methodology and services that may explain some of the differences in certain rates that wouldn't necessarily be evident in publicly available fee schedules and service descriptions? And are there services where current rates contribute to access or quality issues? And do those issues then impact other parts of the service system? So at this point, I'm going to ask everyone who would like to speak to go ahead and raise your hand. If you can't find the hand raising button, go ahead and chat to us in the chat and we will start unmuting people. Thank you.
Okay, first up I have Eric Berry. Hi there, can you hear me all right?
Yes, we can.
Hi, my name is Eric Berry. I'm a financial analyst for Panquist Cap in Bangor. And the services that we provide related to this call is Section 97 PNMI Appendix E. One thing I wanted to comment related to payment methodology and services with the rates as far as PNMI Appendix E, Section 97, is while we appreciate being able to ask for the rate that we need, we think that the it's not necessarily like comparing the rates where our issue is right now. It's with the cost report. We believe that when we submit rate settings, it's all based on each individual services or agency's services, and the 35% allowable reimbursement rate cap should be what's being looked at rather than a comparison of rates. We think that there isn't a good flexibility to be able to request an increased rate based off the cycle of when they're due for PNMIs if there's unforeseen circumstances like COVID, and it impacts us negatively when that happens. So I just wanted to point that out as far as when comparing rates, it's based on the rate settings, and every agency is different when they submit it at the beginning of the year. I think more of what should be looked at is the 35% allowable rate cap as it pertains to the cost report for rate comparison. Thank you.
Okay, thank you, Eric. Next up, I have Rick Erb.
Hi, this is Rick Erb. I'm the president of Maine Healthcare Association. I will be mostly speaking about PNMI Appendix C facilities. Although recent years have seen fewer residential care closings than nursing home closings, underfunding is still an issue for some facilities. The number of closures has been offset in some cases by new facilities opening, so it is not quite as evident. But still, in 2018, the aggregate shortfall for reimbursement was around $3.5 million. The majority of these losses were in multi-level facilities. That may be due to increased costs of compliance with nursing home standards spilling over into the assisted living portion of the building. The 52 multi-level facilities where PNMIs share space with nursing homes are a key piece of the continuum in Maine. As we discussed in the earlier listening session on these facilities, the methodology around PNMI reimbursement has advantages over the nursing home reimbursement. The ability to retain savings on allowable costs helps facilities to remain solvent. But we do recognize that PNMI rates have not been subject to an overall review in more than a couple of decades. It may not be an immediate priority among all of the rates that you are studying, but should be on the list for further review and analysis. As Myers and Stauffer noted, there are few, if any, similar programs in other states. Maine has provided a higher level of care than most assisted living programs. As DHHS has noted in the past, at least a quarter of the Appendix C facility residents qualify for nursing home eligibility. This number has grown through the years as more residents age in place. When looking at these rates, I would encourage DHHS and its consultants to consider the cost of nursing home care. It may be as valuable to compare these costs as it is to the typical assisted living setting in another state. Maine is also unique in its high utilization of Medicaid in the assisted living setting. On average, 70% of Appendix C residents have been paid for through Medicaid over the years. Finally, I would urge the state to look closely at the rates for adult family care homes, perhaps sooner. They are often forgotten because of their small size and rural location, but they serve a very similar population to those in the Appendix C PNMIs. These average rates quoted in the report were a little over $50 a day. My way of thinking, there should be closer parity between the two types of facilities, meaning the Appendix C PNMIs and the adult family care homes. And that concludes my comments for today. I want to thank you for the opportunity to speak.
Okay, thank you, Rick. Next up, I've got Margaret.
Hi, my name is Margaret Longsworth. I'm the Director of Mental Health and Clinical Services at OHI. I'm speaking today about PNMI Appendix E, although we do provide services under Section 21, Home and Community-Based Waiver, Section 13, Section 17, Community Mental Health, and 92. I think that the methodology, the payment methodology for PNMI Appendix E works well. It allows providers to submit for rate adjustments as wage pressures and other costs increase. The trouble comes to the cost settlement. If we haven't been able to hire and retain as many staff as we've projected, then we end up with these paybacks, and that's certainly tying up money that might better be spent elsewhere. And that really gets into the heart of my comments. While the rate methodology for the PNMI is good, the methodology is only as strong as its weakest link in the main care chain. And as the wages in the PNMI, they're really tied to the other service areas. And, most providers have diversified services in order to survive. And we need to balance the wages that we pay across the different services. If you raise something, you raise the wages too high in the PNMIs, and everybody wants to leave Section 21 and come over to PMI, or they abandon all the community mental health services. And this is particularly important in these paraprofessional positions where folks are not making a lot of money. And that brings me to a concern about the studies that Myers and Stoffers have been doing. The 5 comparison states, New Hampshire has a minimum wage of $7.25, as does North Carolina. Montana's next at $8.50, moving to $8.75 at the beginning of the year. Vermont's at 10, I think 96, moving to $11.75. Connecticut's the only one also at $12 an hour, and they just got there. So by January, Maine's minimum wage will be higher than all the comparison states. And while this might not have a big impact on some of the higher level services, med management, things with nurses and whatnot, I think it has a big impact on those lower level services, community support services, DLS, skills development, community rehab service, and that in turn impacts the PNMIs. The success and the long-term efficacy of the PNMIs rests heavily on our community support services. And so in a way, I'm giving a plug to the community support services in hopes that it helps the PNMIs be better utilized. I think it would be a mistake to continue to put efforts into really expanding the PNMI Appendix E's while short shrifting the community support services. If we can get people out of the beds faster, then we won't need as many beds. So those are my comments. Thank you.
Thank you, Margaret. Okay, I am not seeing any new hands. If you had your hand up and you have no more comments, if you could lower it, that way I can tell if you had, something else that you forgot to say and keep track of people who want to add an additional comment. Thank you. Next up, I've got Paul Dan. Oh, or I did. Excuse me 1 second here. There we go.
Can you hear me?
Yes.
Okay, thank you so much. I'm Paul Dan. I'm the Executive Director of NFI North. We provide PNMI services, both adult and children, as well as Section 65 services. A couple of comments. I want to echo some agreement for what's being said with regard to the differences when we start to look at the different states. So I think it's important to recognize that some of the states have from a livable wage standpoint, they're quite different than what we see here in Maine. So it's a little apples and oranges to do some comparisons. I would agree with those comments. With regard to the anomalies with children's PNMIs, I saw in the analysis that they were looking at PR TFs with regard to what's happening in Montana at $610, and there didn't seem to be other comparables. One point I'd like to make with regard to Montana's PRTFs is that they have 3 of them that they're operating currently, and they have 48 beds, 52 beds, and 60 beds respectively. So it's definitely a very, very different system. And you could also just look, and based on our $336 a day on the per diem there, you could see that there's a real disparity in terms of amount of reimbursement we have. Because certainly most of our PNMIs and the children's sides of things are small. Certainly they're not in the 48, 52, or 60 bed configuration. So I just would urge some caution and point out that this shows some discrepancy between them. The other thing I want to speak to is we've been talking a little bit about the differences between minimum wage in the various states. I guess what I would ask is that in the calculation for rates, that the measure not be minimum wage. In fact, minimum wage is, in a sense, a race to the bottom in many ways. That we much more take a position of livable wage that should be calculated into the rates based on the location. You know, some parts of Maine are more expensive than other parts of Maine to live in. That should be based on the educational requirements for the particular position. I also believe that as we set rates, we need to consider issues of parity. We regularly see employees that are become well-trained and capable to support our system, accept positions with the state at a higher rate of pay, or accept positions within the hospital system at a higher rate of pay. So we need to, as we begin to build rates, make sure that we do them in a way that we're meeting livable wage for folks that's comparable for their training and that addresses issues of parity, so that we can stop the churn in terms of losing employees and impacting our ability to deliver services. I believe that's what I have for comments. Thank you.
Thank you, Paul. Next, I have Heidi Meyer.
Hi, this is Heidi Meyer from Uplift Incorporated. We provide Appendix F PNMI services. And I would just like to echo some of the concerns about comparability that were expressed by Margaret, I believe her name was, and others. Although there wasn't a lot of data comparison for Appendix or any data comparison available for Appendix F PNMIs, knowing that other states' minimum wages are much lower, as well as the way that services are provided by public entities as well as private entities, makes, I think it's very difficult to compare apples to apples in the services we provide. Those are my comments. Thank you.
Thank you, Heidi. Let's see, I'm not seeing, oh, here we go. Catherine.
Hi, this is Catherine Thibodeau. I am on the board of directors of MAXPE, and I co-chair the PNMI committee. I didn't catch the name of the gentleman from NFI, but that I really would like to echo those comments. And mine is more of a question, and I know I won't get an answer, but I just am curious as to when, during the benchmarking process, when there is nothing to benchmark against, as is the case in the PNMI Appendix F, how is that going to be handled? And what is the process when there is there's nothing there as a benchmark? And that's really all my comment right now.
Thanks for the comment. That's a good point. That was a struggle with the PNMIs in particular, that it's great to create models that uniquely serve a population, but that makes them very difficult to compare to other places that don't have comparable models. So I think, the strategy really was to not try and force a comparison that would not reflect the services, because that's not helpful to have a comparison that's not a comparable. But I think one of the reasons why we're having these meetings and have had the prior is that the benchmark is only one piece of the total story when we're talking about, making recommendations and prioritization. So some of the feedback about, while we're not compared, but there's some issues with the rate methodology, some of the feedback in the original meetings about how the methodology is possibly creating sustainability or access issues, that would factor in for this model when we look at recommendations, rather than starting with the benchmark percentage of we're over or under the comparison states. That part of the conversation wouldn't exist for PNMI, but all of the rest of it would exist. So all of those concerns and things can factor into the recommendations. Does that help answer your question?
I didn't know if I had to raise my hand to get unmuted, but.
You should be unmuted.
Oh, can you hear me?
Yes.
Oh, okay. I just said thank you for that response. It was helpful.
Okay, thank you. Up next, Heidi. Did you have an additional comment, or sorry, your hand's still up?
No, I'm sorry. I just haven't unraised my hand.
Not a problem. Okay, I am not seeing any new hands or anything in the chat or Q&A. Okay, I've got one more here. Mallory.
Oops, am I unmuted?
Yes, we can hear you.
Okay, this is Mallory Schwartz with the Alliance for Addiction and Mental Health Services, and a couple of sort of broad points highlight that Appendix D is similar to the other one that was mentioned, in that there is really no benchmarking for it, and that's a concern. And then I have, just sort of on a broad level, a couple of comments. When you look under the summary of when services had been, rates had been reviewed before, you see under 97B and 97D in the summary page that the base rate is historical staffing costs, all that it references, and it states of July 2018 and July 2016. And I have real concerns with that, because there were no big rate increases for those services at that time, and the historical staffing costs are quite historical. So I'm not sure where that came from, but it is a real concern that that is contributing to what you're looking at as part of this. Another kind of overarching piece is where you look at the procedure description. Overall, it talks about outliers. And so when we're looking in these comparison tabs of the Excel spreadsheet, noted high or low as an outlier, the high outlier is 120% of the comparison rate, so 20% above the comparison rate, whereas the minimum, the low outlier is not an outlier until it's less than 40% of the comparison rate, as opposed to, say, 20% below, which might be 80%. So I'm not sure where those things were determined or why they were determined that way, but it seems that if you're going 120 as the high outlier, 80 would be the low outlier, or below 80. So just want to make point of that, and that's going to be related to all these services, but just on a kind of a broad spectrum, that's a real concern that we have. And I would echo what some of the other folks have been saying about the minimum wage, and not just the minimum wage, but then the compression that you have to the clinical wages and the folks that have a higher degree and the services and that they're doing and the training that they have and the wages that they're getting. So it has an upward push to have a higher minimum wage across the board. So having a higher minimum wage than any of these other states, I think, needs to be serious consideration of a big global perspective onto any of these when you look at a comparison. So you combine that with the 40% of comparison being a low outlier, seems to me that you're really setting it up to be a you not really capture that impact. So those are some sort of overarching concerns that I have, and we'll be submitting more detailed comments, but wanted to get that on record.
Thank you, Mallory. Let's see. I'm not seeing any new hands or. Okay, next up I have Dale Hamilton.
Hi, Dale Hamilton, Executive Director of Community Health and Counseling Services. We provide Section 97 services, and I guess question / comment about, as you're looking at the different types of PNMI, are you, when you look at these, making recommendations on setting the main care rate, are you also making sure that you understand the totality of funding to those facilities to understand how the rate intersects with the other reimbursement methodologies to sustain the program? It kind of goes back to the comment earlier around the minimum wage and all the factors of understanding the whole composition of the program, how it's reimbursed, and what pays for what parts of the services, and then when you cost settle, the process and how that gets impacted based on the rate. So I'm just wondering if you're diving into the totality of the reimbursement of those programs, or just looking at main care in a silo.
So most of our recommendations are going to be focused on more systemic issues of addressing the system for updating rates, and not specifically recommending changes to individual services rates. So we won't be like rebasing your rates or telling main care how to calculate your rates. We're really looking more at structural, the whole process for looking at rates and pointing out areas where there's been identified as things that may need to be fixed. So I don't think it's our intent to dive into the rate setting methodology to reconstruct or recommend a different reconstruction of your rate. If that's helpful to sort of understand where our scope is, we're really looking at the whole system of rate setting. Did you agree with that, Peter?
Yes, Julia, thanks.
Okay, Dale, I think you are still unmuted if you need to respond.
Oh, okay, great. Thank you for that. I guess I would just add to that, based on that comment, that one of the, and this, I'll say it now, and so I won't say it in all the other, we deliver other services. But as you're looking at that recommendation, one of the things that you asked about is that sustainability for the financial stability going forward. And one of the issues that we run into is the lack of any kind of automatic trigger that keeps the rate at a pace with the cost of living. And this is how we end up with stagnant rates for salaries. This is how we end up with not being able to recruit staff because we can't change salaries. So I certainly hope that as you're looking at this, that you will look and consider whether or not our rate setting process includes an automatic process, so that as organizations we can continue to support the services by having rates that adjust to the factors outside of our control.
Thank you, Dale. Next up, I've got Mallory.
Hi, sorry, back again. Mallory Schwartz, the Alliance for Addiction and Mental Health Services. Just wanted to follow up on your comment about the structural piece and how you're really wanting to get at what are the structural components and is it captured correctly to set the proper rate, and not that you're getting specifically into rates. But I have to say that in this process that we're in, you're not diving into other states as comparisons as to what the structural makeup of their rates are. You're simply doing a high level comparative of a base rate without really looking at how it's created. So we're presented with these comparative rates without having that structural piece behind it. We don't really know for sure what we're comparing to, and if it's actually a comparison that could even hold up. So it's a concern that we're not diving more into the structure of how they're built, but we're just looking at the number and the comparison to that number. And the other piece that I would share too is I believe we're talking about all PNMIs today, and I think that it is noted in there that substance use services are very low, even in the comparison that's being done. But I didn't see specifically the substance use residential PNMIs, and maybe I've missed that.
Just for Claire, are you asking if we benchmarked the SUD PNMIs? Was that your question?
Yeah, I see, substance use, key points and outpatient services, et cetera, but in opioid health homes, but not the PNMI.
Right.
Maybe I'm missing it.
No, we actually did look at trying to benchmark it to the other state models, and to your point, the other residential models in other states were not similar enough to just pull a rate and try to make some comparison. So the SUD PNMIs were not included. We didn't list a rate in the comparison for that.
Okay, I just wanted to make sure I wasn't missing it because I looked all over. Thank you.
Okay, thank you, Mallory. I'm not seeing any new hands or comments at this time. Okay, I've got one more. Paul Dan.
Hello, Paul Dan, still with NFI North. Thanks for having me back. I just want to underscore the point around rates that are set based on cost, when in fact we've had a system that's been quite anemic for many, many years. And to believe that someone has survived or a service has survived, for example, based on a particular cost that they've shown doesn't mean that the service is getting the kind of resources ultimately that they need. I think if you were to speak with the folks at OCFS today, they're hearing that multiple children's PNMIs, for example, are closing. And the reason for that is that, yeah, they've plugged along over the last number of years, but the amount of resources that they've received and then been able to spend are not enough to sustain the service going forward. So I would just caution against any type of just straight cost, historical cost-based rate setting, because it's likely a situation where things have not been fully funded and people are kind of band-aiding and fish wiring things together, which in the end doesn't make for a robust or successful delivery system. Thank you.
Thank you, Paul. Next, I've got Jeff Tyner.
Hi, this is Jeff Tyner. Can you hear me?
Yes, we can.
Okay. Jeff Tyner, I'm the Chief Program Officer, Clinical Services for Catholic Charities. And I just want to harken back to something that Mallory had shared, because I too was looking for Section 97 for the substance use disorder residential, which we operate one in Auburn. So not only are we waiting around, the possibility of being able to expand with the IMD waiver request, but I can tell you we run level 1 and level 2 services for that much needed service in the state. And we really hope that there is some plan to be able to, even if you don't have comparative data, to be able to address that in some way, shape, or form, to be able to create a sustainable service, because we certainly struggle with the churn that Paul mentioned earlier, and all the other comments that my colleagues made. I certainly echo. Thank you.
Thank you, Jeff. Next up, I have Sean Quimby.
Hi, can you hear me all right?
Yes, we can.
Thank you. So I just want to echo all the comments that folks have already made about the wages and cost of living and the minimum wage and that kind of thing. But I'm a clinician by training, and for me, this is really an issue about quality. Not only is it an issue about being able to just keep our programs open. I'm aware that a number of programs have had to close, unfortunately, recently due to staffing concerns, which of course is impacted by COVID, but it's impacted by our ability to pay folks a competitive wage. When I first started in this business some time ago, the vast majority of our direct care staff, who I'm sure we all know do the bulk of the key work with the youth and the families, they were predominantly folks that had bachelor's degrees and would stay with us for years at a time, which frankly is what it takes to kind of build and mentor a really quality staff person. And we just don't have those folks sticking around anymore, and we've gone from maybe having 2/3 to 3/4 of our folks with bachelor's degrees to having a fraction of our staff with bachelor's degrees, and having a complete inability to maintain those folks for even long enough for them to get their feet under them. And I certainly think that over the years, some of our best folks we've worked with haven't had bachelor's degrees, but there is there's something to be said for someone that's able to obtain some basic education around trauma and clinical interventions. And there's some work ethic that goes into completing a degree, and just the quality of employee is it's who I would want working with my kids. And these kids are not quote unquote normal kids. They're young people that have had just incredible traumatic experiences. And so anyway, I won't ramble on any further, but just it's a quality issue, and I'd really like to see. We've lost a lot of that over recent years because of our inability to compete, and I hope folks keep that in mind as decisions are made around these key issues. Thanks.
Thank you, Sean. I'm not seeing any new hands or anything in the chat. Okay, I've got Justin Gifford.
Hi, good afternoon. Justin Gifford. I'm speaking on Section 97, Appendix D, Children's Residential. I did put it in the chat, but maybe I did it incorrectly. Just in terms of comparison, Maine, when children go on therapeutic home visits, it's considered a bed hold day, whereas the program or the facility is not paid, including the room and board or treatment rate, which isn't consistent with a comparison in terms of some of the other states. I would certainly echo sentiments of most of the people speaking on Section 97. Our rates were in kind of our treatment programs facilities were predicated on a rate that was last increased nearly over a decade ago, which moving forward, obviously wages, 10 years ago, we could hire a nurse for $40,000. Right now, we're offering between $60,000 and $70,000. And again, regardless with the comparisons, most of us have built our programs, facilities on a rate which has certainly not kept up with the change in fixed goods and labor. Thank you.
Thank you, Justin. Next up, I have Rosalie.
Yes, I represent Ashland Campers. I have a vocal cord issue, so that's why I typed my concerns. As an adult family care facility, we often fall through the cracks, and many of the rates that are set don't cover our cost of operation, and we kind of get left behind.
Thank you, Rosalie. We have recorded your spoken comment and your written comment.
Okay.
Thank you. I'm not seeing any new hands or anything else in the chat. I've got Margaret.
Hi, I just wanted to second the comments made about livable wage and wage compression. Those are significant issues. Thank you.
Thank you, Margaret. I've got Mallory.
Hi, just again, to reiterate the comment that was made about the need to tie whatever rates do end up coming out. The process has to be tied to a cost of living index of some type so that we're not constantly back here again with, you said in a children's, say, mental health residential in the state of Maine was a, very well done system at one point, and home and community as well, but very good system at one point. But when so much time goes by without those increases, it does decline in its quality and availability. And so if we're talking process and structure, that has to be a part of it so that it does continue to just move forward with the cost of doing the service. So just really reiterating that. Any structure's got to have that.
Thank you, Mallory. Okay, next I have Clement.
Yeah, hi, my name is Clem DeVoe. I'm Program Director at AMHC. Specifically, I'm going to be talking real briefly, just mostly a comment around Section 97D, Children's Residential. I just want to echo the comments of my colleagues in terms of rates, and we've identified all of those, so just reiterating that. But I think Justin Gifford identified some particular, and that is bed hold days. One of them being either home visits. One of the ones that comes up frequently is if individuals need higher levels of care, of which we would then hold the bed for a period of time if a child needs hospitalization, for example. And that could be a month, or sort of include consideration of bed hold days, especially for advanced level of care and treatment, in terms of what compensation rate could be associated with that, since that bed is being held with no revenue during that time, in addition to some of the things that Justin identified in terms of home visits, etc.
Okay, thank you. Okay, I'm not seeing any new hands or anything in the chat right now. Okay, Julia.
Okay, great. Thank you, everyone who commented. I want to give you one last opportunity. If you haven't made your comment and you'd like to, please let us know. Otherwise, you are more than welcome to submit written comments at ratesettingeval@maine.gov.
I've got one new raised hand, Mallory.
Yes, sorry, that actually brought forward another question, which can you hear me okay?
Yeah.
Okay. We were told that the 9th would be the deadline for written comments, and we are requesting that we get a little bit further time so that we can dive a bit deeper into the comparisons with these other states and the structural pieces that we need to look further at.
Hi, Mallory. A listserv went out earlier today. We've extended the deadline through the 11th.
Thank you. I hadn't seen that yet. I've been in Zooms all day.
I understand.
Thank you.
You're welcome.
Great. Well, thank you everyone so much for giving us some of your time this afternoon. We really appreciate it. Don't forget to send us written comments if you'd like, and have a really good rest of your Friday. Thank you.